Hello everyone. Today I'll be talking to you regarding Budd-Chiari syndrome, Wilson disease and hemochromatosis. And I'll be including all these subspecialties which are relevant to my talk. The first topic of the day is Budd-Chiari syndrome. So first of all, let's learn what is the definition of Budd-Chiari syndrome. The key factor is hepatic venous outflow obstruction. That means there is some problem of venous return from the liver is the key factor. So this is the first key word to be remembered in today's lecture. Now this problem can happen at what place? The problem can happen at the level of hepatic venules, large hepatic veins or inferior vena cava. Okay. Now this you will not understand unless we know the basic concept. So let's learn the basic concept. The basic concept, this is the liver and it is the hepatic vein. HV stands for hepatic vein. This is liver. And ultimately this drains into inferior vena cava. And this inferior vena cava goes to the heart and it enters the right atrium. This is right atrium. So the blockage of the blood flow can be at the level of right atrium. Normally it is not a very important cause, but it may be at the level of inferior vena cava. Number one, maybe at the level of hepatic veins also. And there are certain hepatic venules before they really go, hepatic venules. Blockage can be at the level of hepatic venule also. But point to be noted that we know very well these hepatic venules, they get blood from the sinusoids. Here is the hepatic lobule, central vein, hepatocytes and portal tract. And here we have sinusoids. Sinusoids. Point to be noted, sinusoid blockage is not a part of Budd-Chiari syndrome. Because sinusoids we know very well, they are blocked in cirrhosis of liver. So that is not a part of Budd-Chiari syndrome. So primarily that means out of these are the most important thing, two sides where we usually talk about Budd-Chiari syndrome. Out of these two also, this is much more important and common, about which I am going to discuss in a minute only. So we are learning that three places, hepatic venules, large hepatic vein and inferior vena cava are the three sides. As I told you, sinusoidal obstruction is not a part of Budd-Chiari syndrome, that is a part of that what we see in cirrhosis of liver. Okay, so we are clear about the definition. Now obstruction can be at three major sites of the obstruction are hepatic vein obstruction. I just show you the beautiful picture, hepatic vein. It's the most common site, point to be noted. Now what are the causes or condition where hepatic vein obstruction occur? Pregnancy or postpartum state is a very, very important condition. Okay. Similarly, oral contraceptive. So now what else we are getting information from? This means this hepatic vein obstruction is very common in females. Young females, why? Pregnancy and oral contraceptive are usually the concept of young or middle-aged ladies at the most. Malignancy, hepatocellular carcinoma is a very important condition. It can invade hepatic vein. Underlying liver disease like cirrhosis or hepatitis. Point to be noted, cirrhosis of liver as such does not lead to Budd-Chiari syndrome, but later on they can lead to malignancy, etc., which can lead to invasion of the hepatic vein. But deliberately, cirrhosis is not a part of Budd-Chiari syndrome. A hematological condition like PNH, PNH is paroxysmal nocturnal hemoglobinuria. PNH, polycythemia vera, sickle cell anemia. It means what? The clinical applied, that whenever we are getting a case of Budd-Chiari syndrome, his blood investigation should be done fully. Especially the complete blood count, peripheral smear should be made to rule out any of the hematological conditions. It can occur in sarcoidosis and vasculitis also. There are some of the conditions. So by and large, if I have to give you three words, the one key word is pregnancy, oral contraceptive. Second is hepatocellular carcinoma. Third is the hematological condition. So they are the three summarized causes, maybe pregnancy. Number two is hepatocellular carcinoma. Third is the hematological conditions you have to look for, right? So nice summary of the entire table given to you. Then inferior vena cava obstruction. This can be congenital or again hepatocellular carcinoma. Again we go back to basic. So what I told you just now, that hepatocellular carcinoma, this liver cancer can invade hepatic vein. This liver cancer can even invade inferior vena cava also. Okay. Now, so we learned about two places. Now, there are hepatic venules. These are the venules which have come out of the sinusoid and they are about to join the hepatic vein. Even they may be involved. So, small venules, hepatic venules of, okay. This is veno-occlusive disease. It's a very important condition. Although it is seen in only some part of the African countries, but it's a very widely asked question in the exam, so I'll talk more. So veno-occlusive disease is a fibrous obliteration of hepatic venules and small hepatic veins. So whatever veins I was trying to show you, liver, hepatic veins and the small veins which are tributaries which are going to join hepatic vein, these get fibrosed and they get obliterated. And the reason being because these people in some part of the North Africa, they consume a bush tea. Okay, that's why they call as bush tea disease. It's a wild variety of tea and that contain an alkaloid so called pyrrolizidine. So this alkaloid, these people they develop fibrosis and obstruction in the small hepatic venules. The key word to be remembered here is veno-occlusive disease is the only keyword that you got to remember. Azathioprine is a very commonly used immunosuppressive drug. It may be a part of graft versus host reaction also. Point to be noted, both are involved in the after the transplantation, radiation. Of course, radiation again we go for some malignancy, and this may occur in inflammatory bowel disease also. So by and large in this, the two important keywords to remember are veno-occlusive disease and azathioprine are the two important keywords to be remembered in this particular slide. So overall, two keywords, only one keyword, and the three keywords, that is hematological condition, pregnancy, and hepatocellular carcinoma. So they are the only 5 keywords to remember in causes. Now what is pathophysiology? So it is affecting more young females, the reason I told you, but it is a keyword to remember. That means problem is, of course, it can occur in males also, but young female, due to very obvious reason I told you. Well, so in this ultimately the most common site was hepatic vein, and they lead to hepatic venous thrombosis. The 2 point you already learned in the pathophysiology, but now the things are much clear. So what happened? Again we go to liver get acutely congested. Let's learn the basic concept. The basic concept goes like this. Here is the liver and here is the hepatic vein and inferior vena cava. Obstruction occurs in the hepatic vein. So definitely the blood flow will be totally stopped. Point to be noted that liver gets blood about 1250 ml of the blood per minute. This much is the blood. So in the pathophysiology, it's more in young ladies. The reason being, I already told you, maybe pregnancy related or maybe oral contraceptive. And of course, it is the problem lies in the hepatic venous thrombosis, the point we discussed. So let's learn this, the liver. Here is the hepatic vein and here is the clot. Well, just to inform you, liver gets about 1250 ml of the blood every minute. That means liver gets around 25% of the cardiac output. Liver gets. So now this 20 definitely same amount of blood which is entering the liver will also be coming out of the liver. Now if there is a sudden blockage of this hepatic vein, clot formation, so definitely huge amount of blood will get accumulated. Immediately liver will try to expand like a balloon like this. It would try to, but it has a limitation. It has a capsule around it. So it cannot, of course there is a limit to beyond which it cannot expand. Everything is congested, all the sinusoid and hepatic veins and intrahepatic venules, they all will be congested, right? And since liver is totally enlarged, it will try to burst. Of course, it will not burst, but it will try to. So it lead to severe pain in the right upper abdomen with a presentation like this. Okay, but fortunately, sudden obstruction is uncommon as compared to gradual obstruction. That means if it is a hepatic vein, clot will form. Gradually it will try to expand. To make a thrombus is there, gradually it will expand. So by the time the patient develops complete occlusion, already lot of collaterals have been formed. So liver will be congested definitely, and especially in the long standing cases, patient will develop portal hypertension. If the portal hypertension will develop, so now I don't need to tell you, patient will develop ascites as well as esophageal varices will be there, right. So the additional finding will be there, more likely to be seen in case of varices etc., are more likely to see in chronic slowly getting obstruction is there. But in acute problem, it may likely to go into fulminant liver failure, point to be noted. So point to be noted, acute is more likely to come like a fulminant liver failure, and in contrast the chronic one which is more likely to come as a portal hypertension. So two keywords: chronic portal hypertension, acute fulminant liver failure. But abdominal pain and discomfort will be there of course in case of chronic, but it may occur in acute also, okay. Ultimately chronic one, they can go into cirrhosis of liver. So if I have to give you three keywords: acute fulminant failure, chronic portal hypertension, cirrhosis of liver, three keywords in these two particular slides. Keyword pathology. In the early stage there will be congestive hepatomegaly. Why? I told you, there is a blockage of blood flow. The entire sinusoid and small intrahepatic venues, they all will be congested, and later on as the condition advances, after a few months, the patient may develop cardiac cirrhosis. So it is it is a cirrhosis due to cardiac problem. The word we use is cardiac cirrhosis, and classically finding in such cases we use the nutmeg liver. This is a very commonly asked exam question. Nutmeg liver is seen in a case of cardiac cirrhosis, and the hallmark or the classical feature of cardiac cirrhosis is congestion. So congestion is concerned. Now we go into more depth of the pathology. Well, congestion in the liver, congestion is occurring, but congestion occurring where? It is more of a centrilobular congestion. What does this mean? Again we go to the basics, okay. Basic, if you remember the histology, this is the lobule, central vein, portal tract, hepatocytes, sinusoids. These are the sinusoids, yeah. And ultimately these central veins, they are draining into small hepatic venules, which finally drain into hepatic vein. They all come and join and make hepatic vein, right sir? So we understood hepatic venules, hepatic vein. So now blockage is there in the hepatic vein, so the whole thing will be, all backflow will be totally congested, including central vein. They all will be congested, and as the congestion occurs in the central vein, that's why first of all there will be necrosis in the, of course we divide liver into three zones. This I discussed in the histology: zone 1, zone 2, zone 3. So in this zone 3 lies around the central vein. So these cells, nearby cells, they start getting dead. These cells near the central vein, they like to get necrose. So what we call as centrilobular necrosis. So we get centrilobular necrosis occur. So central zone congestion and necrosis is the zone. Zone 3. Zone 3 is that zone which is around the total center of the lobule, around the central vein, and they are the one which maximum get the where maximum load of the problem comes, and that's why they have a cell necrosis. And ultimately there may be some hemorrhage also because of high amount of pressure, some bleeding may occur, and we may get mottled appearance, so called nutmeg liver. You can see beautifully, you can see central veins, and this all RBCs are visible on the screen, and this is called mottling is there, so called nutmeg liver is the term that we use. What is the key word to be? The key word is nutmeg liver and centrilobular congestion necrosis. This is the only key word to remember in this particular slide. The clinical feature, as I discussed, they all depend whether it is a acute onset, subacute or chronic. Well, the presentation can be depending on, especially for chronic cases, gross ascites with abdominal pain. This occur in all the stages. This will happen only in chronic cases. It will not happen in 1 or 2 or 3 days. It may occur, but not gross ascites will occur only in chronic cases. But pain abdomen is a constant feature, and especially in acute complete blockage, shock with fulminant hepatic failure, the point I discussed earlier, hemochromatosis can occur, especially in chronic cases where the patient has developed portal hypertension. So friends, what I discussed previously, these findings what you are getting will be in acute cases, but these hemochromatosis etc., this you will get only when the patient has developed portal hypertension. Well, in such cases, the first investigation done is ultrasound. It's the first investigation to be done. With Doppler flow, we can even come to know how much where the blockage is there. And later on, we do hepatic venogram, and this really confirms the diagnosis. Okay, right? Even inferior venography is done if the blockage is in the inferior vena cava, but it is much less common as compared to blockage in the hepatic vein. Treatment, patient has come to us, we have investigated. Now treatment all depends, it's not a standardized treatment, it is always a tailored. Tailored means depending on the patient presentation, we treat the patient accordingly. Not a single formula is not applicable to each one of them. So this depends on stage of the disease, of the presentation. Stage means it's acute, subacute or chronic, whatever stage, accordingly we plan the treatment. So suppose the patient comes with fulminant hepatic failure, okay, and patient has got, patient may be having cirrhosis. If the fulminant liver failure is there, which is usually seen in acute cases, then the only treatment is transplantation. The fulminant liver failure, transplantation. Write down fulminant liver failure, transplantation. LT stands for liver transplantation. Fulminant liver failure. That means the only keyword to remember in this particular slide is this one. Only one keyword. Fulminant liver failure is liver transplantation. But in those where the fulminant liver failure is not there and cirrhosis is not yet established, then we can go for portosystemic shunt, TIPS or portocaval shunt. Any other shunt we can there. That means in stable cases, Stable cases where the acute fulminant failure is not there, then we can plan for the shunt surgery. And suppose inferior vena cava get compressed, inferior vena cava is getting compressed, then we can use certain stent. Then we can use stent. And of course, whatever condition it may be, patient should be given lifelong oral anticoagulation, right? So I give you whatever I have given the last two slides. Let me give you lovely summaries. Summary of treatment. So what we are finding, hepatic vein obstruction, which is much more common. Okay, patient has cirrhosis of liver with of course normally these patients will have already cirrhosis is there. Listen to my words very carefully. Patient already has cirrhosis of liver and or patient has developed cirrhosis soon after this blockage and he has got acute liver failure. In such cases go for transplantation. But there is no cirrhosis, then we can go for portocaval shunt. Shunt means we are creating a shunt. But if inferior vena cava is obstruction, it was a hepatic vein, now inferior vena cava, we like to go for angioplasty, that we like to put a stent as I showed you in the previous slide. But if both hepatic vein obstruction and there is obstruction in inferior vena cava, this especially occur in hepatocellular carcinoma, then do angioplasty as well as portocaval shunting also done. Okay, so this is a summary of how we are going to treat a case of Budd-Chiari syndrome. So last minute revision point, obstruction to hepatic venous flow occurs at three places. Hepatic vein obstruction is the most common site. Inferior vena cava obstruction is the second common site, or there may be obstruction to small branches of hepatic vein, what we see in veno-occlusive disease. Pathology is nutmeg liver because there is congestive hepatomegaly. Onset may be acute, subacute or chronic abdominal pain and hemochromatosis. Lab finding, ultrasound with Doppler flow, hepatic venogram or inferior venography. Treatment stent, transplant or portocaval shunt, including tips and lifelong oral anticoagulant. This is the treatment. So golden line to remember. Sudden onset of severe upper abdomen pain with ascites in a young lady taking oral contraceptive pills. This is Budd-Chiari syndrome. 99% your question will be based on this particular line only. Wilson disease. First we learn the definition. It is a disorder of copper metabolism. First keyword to remember. The problem lies is inadequate biliary excretion. The second keyword to remember. So definitely copper is coming in the liver, but it is not able to excrete out in the bile. So ultimately this copper goes back to the blood, and in the blood it is taken to three places: liver, brain and eyes, where excess of copper is deposited. As of now, three keywords: copper, impaired biliary excretion and deposited in the brain, eyes and the liver. Detail I will be talking to you soon and you will understand each and every word. But three keywords. It is autosomal recessive. That means it is a hereditary disorder. And very, very important line. It is recessive, but the onset of disease may be between 3 to 40 years. This is the fifth keyword. So friends, a quick recap of the 5 keywords. Disorder of copper metabolism, impaired biliary excretion, excess of copper in the brain, liver and eyes, onset of symptom 3 to 40 years. 3 years is a childhood, early childhood, 40 years is almost a middle age. But majority of time the patient manifests in the late childhood. Late childhood is this. That means somewhere around 10, 12, 14 years, something like that. Agreed. So there are 5 keywords and every word I will be discussing in detail in the next slides. Now we talk about basic concept. What we learned in the previous slide, again we go back. That is a disorder of copper metabolism and impaired biliary excretion of copper, and it get deposited in the liver, brain and eye. Now these 3 keywords we'll talk in detail when we learn the basic concept about copper metabolism. This one topic, normally 99% students are not well aware of this copper metabolism. Well, about 60% of the ingested copper. Now, how much is the normal copper intake? Somewhere around 0.6 to 3 milligram per day. This is the normal copper intake in our diet. Okay, suppose let's say it's 0.6 to 3. For easy calculation, I am taking 1 milligram. Out of this 1 milligram, 60%, that means 0.60 milligram. This will be absorbed in stomach and duodenum. Point to be noted, the site of copper absorption is stomach and duodenum. That is more of a upper part, not the distal part of the ileum. Well, this copper is there, it is getting absorbed. It was in the lumen, it get absorbed, and in the blood it bound to albumin. So this was in lumen, and now this is in the blood. Copper get absorbed to albumin, and now this is taken to the liver. So copper now come in the liver. In the liver it combined with alpha 2 globulin, alpha 2 globulin, and this combine and it makes ceruloplasmin. So this is getting made in the liver. Okay, and finally the ceruloplasmin, which may have been made in the liver, it goes into the bile ductule, and this how the copper which is absorbed from the intestine goes out into the bile in the form of ceruloplasmin. Okay, agreed. So the keyword in this to be remember here are keywords are copper in the lumen, copper with albumin in the blood, copper combined with alpha 2 globulin in the liver to make ceruloplasmin, and finally this goes into the bile ductule. So there are 4 keywords to remember in this particular slide. After that, how much is the normal total copper in the body? It is around 50 to 150 milligram of total copper is there. Point to be noted, per day it was 60% absorbed, and the per day intake is about 0.6 to 3 milligram per day. The total is 50. Now, all the old ceruloplasmin and whatever is unabsorbed copper, 60% got absorbed in GIT, rest 40% will go out in stool. And similarly, 90 to 95% of the ceruloplasmin, 90 to 95% of the ceruloplasmin, CP stands for ceruloplasmin, it goes in bile. But 5 to 10%, 5 to 10% of the copper which was not incorporated into the ceruloplasmin, this will again go out in the bile. It means the total copper whatever was there, 90 to 95% get incorporated into ceruloplasmin by combining alpha 2 globulin. But if 5 to 10% which are not able to become ceruloplasmin, they go out as it is. So bile will contain ceruloplasmin and bile will also contain free copper. And similarly, 40% of the copper which was not absorbed goes out in the stool. So what I mean to say, primarily it goes out via stool, and some amount of may go from kidney also, but primary site of excretion is a stool. So let me give a flow chart of what I told you just now. Beautiful. The last 3 slides is squeezed in one line. We have in the GIT we have a copper. This copper was absorbed and immediately in the blood it goes combined with albumin in the blood. Then this copper come in the liver. In the liver it combined with alpha globulin and it makes ceruloplasmin. And this ceruloplasmin is secreted into the bile, and some amount of goes to the blood also. Okay. Now, in Wilson disease, there is a mutation in gene ATP7B in chromosome 13. Remember chromosome 13. Chromosome 13. Right. So, what happened in this? Look into chart again. GIT, copper get absorbed. Blood, copper albumin, this is there. Finally, copper get combined with alpha globulin, and what is made is ceruloplasmin. So here the problem lies in the biochemistry. This copper combining with alpha globulin in the liver is not there. It's not there. So definitely the ceruloplasmin which was normally made in the liver, which goes out into the blood, will not go. Remember, whatever normal ceruloplasmin is made in the liver, this ceruloplasmin is resecreted into the blood. Normally, the ceruloplasmin which is being made in the liver is secreted into the blood. It goes as, so copper goes in the form of ceruloplasmin in the blood normally. Here this combination doesn't occur. If it does not occur, ceruloplasmin will not be made. If there is no ceruloplasmin, the blood will not have any ceruloplasmin. So blood ceruloplasmin level will be reduced. Okay. Well, now copper is free. It is not getting combined with alpha 2 globulin. Now this excess of copper is in the body. This is cause damage to the tissues because it generates free radical. So excess of copper In fact, copper is in excess because it's not getting combined with alpha 2 globulin, and this excess of copper will be causing damage. So it can cause damage to the hepatocyte. It can cause to cornea and basal ganglia also. Excess of copper which was supposed to be converted into ceruloplasmin is not getting converted. So it is going to other places, also liver, causing damage in liver as well as cornea as well as basal ganglia. So now we come to the clinical features. Patients may have liver disease. Why? You learn the basic pathophysiology. Excess of copper in the liver lead to liver disease. It going into basal ganglia, into the causing Parkinson-like feature in a young adult. This is a keyword to remember. Keyword to remember. Well, normally Parkinson is a disease of the elderly person. So the classical line written in all the major books, suppose you get a 20-year-old patient with Parkinson-like feature, you should always investigate for Wilson disease. Okay. So let's talk about what happened in the liver. In the liver, it can just raise from maybe mild elevation of the enzymes, especially SGOT, SGPT. But the classical exam question in this, alkaline phosphatase is low. Classical exam question. Despite having liver disease, the alkaline phosphatase score is reduced. So the hepatic illness may be limited to race enzyme, or it can go into acute hepatitis. It can go into fulminant hepatitis. It can go into chronic active hepatitis. CAH stand for chronic active hepatitis. It may even go into cirrhosis of liver. So it can be wide variety, right from asymptomatic, which simply raise enzyme, to acute hepatitis, fulminant and cirrhosis of liver can happen. Wide variety. Okay. Now in the brain involvement occurs in around more than 50% cases. So what are the brain findings that we have? Classically in the putamen. I hope you are all well aware putamen is a part of basal ganglia. So it may produce movement disorder like Parkinson disease. Why putamen is involved? And I told you a 20-year-old man come to you with Parkinson like, think about Wilson. Now it may get deposit other part of basal ganglia, subthalamic nucleus. There it produces hemipalesmus. Okay. And I have taken one full lecture on involuntary movement. Those of you in neurology, those of you who have not seen, please go and see the lecture. And in there I have shown you some beautiful videos also, what is hemipalesmus and etc. Well, we are talking about CNS involvement in Wilson. It may even involve the cerebral cortex also. It can produce dementia. And otherwise, it can involve autonomic disturbance also. So, autonomic neuropathy can occur. The keyword to remember is Parkinson, hemipalesmus, dementia, and autonomic neuropathy. So, there are 4 keywords to remember in this particular slide. Then we talk about KF ring. The full form is Care Flash ring, but usually in clinical practice they always talk about KF ring. Well, the main problem is excess of copper. Now this excess copper create problem in the liver, it got deposited in the CNS. Now this excess of copper getting deposited in the cornea also. Cornea where? Descemet membrane of cornea. Point to be noted. It's a very important point. The way in the basal ganglia it got deposited in the particular place is putamen. Particular is subthalamic nucleus. Similarly in the eyes, in the cornea, typically in the Descemet membrane. How we can see? We can see by slit lamp examination. Of course, in very advanced cases this can be seen otherwise also, but a better answer is slit lamp examination. But one more thing, it is not pathognomic only of Wilson. This can be seen in primary biliary cirrhosis also. Also seen in primary biliary cirrhosis. So as of now in this, there are three keywords to be remembered. The first keyword is Descemet membrane of the cornea. Second keyword is slit lamp examination. And third is also seen in primary biliary cirrhosis. Okay. Well, additional feature that we can see in these patients in Wilson disease, renal calculi, amino aciduria, and this is due to renal tubular acidosis, so-called Fanconi syndrome. And a simple question for the students. Tell me in question only for the student. Tell me, we write as RTA, renal tubular acidosis, Fanconi syndrome. Tell me in which type of RTA, type 1, type 2, type 4, where we get Fanconi syndrome. All the students write down the answer in your copy. Just write down the answer. In which type of RTA, type 1, type 2, type 4. Well, the answer is type 2. Okay. This is also known as proximal renal tubular acidosis. The other feature which can happen in these patients uncommonly is hyperparathyroid, infertility, hemolytic anemia, and cholelithiasis. They are the uncommon problem that can be seen in these patients. Hepatoma can develop, but not very common as compared to hemochromatosis. Testicular atrophy can occur, but not as common as what we see in hemochromatosis. These two problems are much more commonly seen in hemochromatosis. How we diagnose? But I told you, a 20-25-year person coming to you with neuropsychiatric features, and well, suppose a 20-year-old boy come to you, suppose you are sitting in the OPD, a 20-year-old boy come to you with Parkinson-like feature, which are very obvious. You can see the gait, you can see the tremor. Well, you should, first thing the possibility should come to your mind is Wilson. What you will do, what you should do, you immediately send that patient to your eye specialist friend and ask him, write a short note, please look for the slit lamp, look for the KF ring. If you are getting KF ring, it is very easy to say that perhaps you are dealing with Wilson disease. Indicates. Now you got some reason, now you are going to investigate. Ceruloplasmin level, it will be reduced. Why? Normally ceruloplasmin is being made and normally it goes into the blood. 90 to 95% goes into the blood. 5 to 10% goes in the bile. Okay, this is normal physiology. But here this ceruloplasmin is not being made. So there is no ceruloplasmin. Normally it goes to the blood. 90 to 95% goes to blood, 5 to 10% goes to the bile. Okay, bile. So here there is no ceruloplasmin is being made. So no ceruloplasmin is made, neither it will go to blood, neither it will go to bile also. So that's why there is no ceruloplasmin. So ceruloplasmin secretion is impaired, the basic pathophysiology what we learned it. So serum ceruloplasmin level is reduced, maybe less than 20 milligram per 100%. And increase copper excretion. Why? Copper is not getting metabolized. So now copper will be starting more and more taken part of the whole body. So in the urine, copper will be increased, or we can see KF ring. And ultimately in due course of time, the total serum copper will reduce. Why? Total. Point to be noted, total. In due course of time, total copper will get reduced in the body because there is no ceruloplasmin being made. But at any given time, the serum copper level and there is increased urinary copper excretion. But total copper include bound form of copper also. So decreased serum ceruloplasmin is a very high sensitivity, 85% sensitivity, and it is very useful investigation in the early stage of the disease. But in the late stage of disease, it is better to look for serum and urine free copper level. They are increased. Ceruloplasmin is a bound form, point to be noted. But the most accurate is liver biopsy, and you can see elevated hepatic copper concentration, more than 250 microgram per gram of dry liver. So finally, you want to confirm, you want to see the copper in the liver biopsy. So a quick recap, the keywords are in the diagnosis. The keyword in the diagnosis are, first keyword neuropsychiatric feature. In a young person, look for KF ring, reduce serum ceruloplasmin level, increase urinary copper excretion, and okay, so they are the 4 keywords to remember. Point to be remember, this is for early, this is for the late, and this is the first thing to be done. The first thing to done is KF ring. Number 2, in early stage, reduce serum ceruloplasmin. In the advanced stage, increase urinary copper excretion. And finally, the most accurate test is biopsy. 4 keywords so far. We can also go for MRI. In the MRI, we look for basal ganglia problem. But this basal ganglia problem is not specific. It will simply add on to diagnosis, but it's not a diagnostic investigation. Now, how to manage this case of Wilson disease? Well, so whenever we diagnose a case of Wilson disease, we have to assess severity. For that, we use Nazar criteria. This is a keyword. We use Nazar prognostic index. The score is below 7. You try to manage by medical therapy. And what medical therapy that I am going to discuss in the next slide. But the score is above 9. It should be immediately treated with liver transplantation. Okay. Point to be noted, below 7, medical therapy. Above 9, without wasting, liver transplantation. Between 7 to 9, plan for liver transplantation. The only problem with the liver transplantation is non-availability of the donor. So what are the Nazar score based on which criteria? don't write, you just have to write this. It is based on these criteria: bilirubin, AST and INR. They are the three parameters that we use. Different scores are given. Do we need to remember? Not at all. Not at all. What you have to remember, the parameters are bilirubin, AST and INR. INR is international normalized ratio that is involved in prothrombin time. In prothrombin time. So the parameters are bilirubin, AST and INR or prothrombin time, whatever you can say. INR is better. So just remember the parameter on which it is based. And if the score is below 7, treat medical therapy. 7 to 9, plan for liver transplantation, and above 9, immediate urgent liver transplantation, otherwise patient will die. So now how to? So medical therapy, definitely it will be done when the NEDA score is below 7. In below 7, we go for medical therapy. What therapy we give? Ultimately, we want that whatever copper has been in the body, we have to remove it. Okay, whatever extra copper is there in the body, we want to remove it. And number 2, we don't want it should reaccumulate. So our aim is to remove, we want to remove whatever extra is there, and we want to prevent reaccumulation. We don't want it should reaccumulate. The first line, of course, whatever extra copper is there, we want to remove it. For removal, for removing, we use copper chelators, that is dipenthamine and trientine. They are the copper chelator, they are going to remove excess of copper from the body. And second, we don't want that copper should come, we don't want it to reaccumulate. We use zinc, it inhibits reabsorption of copper in GIT. So this is the GIT, this is the copper in the body like liver, lot of copper is there, copper is here. So our aim is that this copper should not come in. Our aim is this copper should come out. This is our aim. If we want copper should come out, we will be using chelators like dipenthamine and trientine. Dipenthamine and trientine. We don't want that copper should be absorbed, so we will be using zinc. It will not let copper come in. And when we have one more drug which will reduce copper reabsorption is ammonium tetrathiomolybdate. It also compete for copper reabsorption in bowel, so it will not let copper get absorbed. Again acting here, but it has an additional advantage. It also causes increased copper excretion in the urine. More and more copper will go out in the urine. Additional advantage which is not there with the zinc. So this additional advantage. Finally, liver transplantation, especially more than 7. The NEDA index is more than 7, and if it is more than 9, it should be done on emergency basis. So LMRP, chromosome recessive, usually under the age of 40 years, but normally they present around late childhood. Chromosome involved is 13. Liver disease and Parkinson-like feature, KF ring. And the most diagnostic feature is liver biopsy. We use Nazar prognostic index, which is based on bilirubin, AST and INR. B for bilirubin. Zinc and trientine, Zinc will be what? It causes reduced absorption. Triantine and penicillamine, they are the chelators. They chelate excess of copper. And finally, the liver transplantation. Golden line to remember. A child or young adult presenting with liver disease and Parkinson-like feature with KF ring, this is Wilson disease. Forget everything. Your entire question will be based on this. Additional thing what you can write is reduce serum ceruloplasmin level. That's all. First keyword, second, third, fourth and 5. There are only 5 keywords you remember. You can answer any question on Wilson disease. Hemochromatosis. Definition. His excess of iron reabsorption in GIT. And excess of iron comes in. So this is going to increase iron in the body. And excess of iron will damage many of the organs. Etiology. It is recessive. And in fact, hemochromatosis is one of the most common inherited disease, and it also one of the most common inborn error of metabolism. So the key word is autosomic recessive, most common inherited disease, and of course most common among the most common inborn error of metabolism. So there are 3 keywords in this particular slide. HLA-A3 association is there, but what is more important is much more common in males as compared to females. Now a question only for the students. Tell me what the reason why this disease is more common in males, very uncommon in females. Any special reason? Write down question only for the students. Write down the answer in your copy. Well, by now you must have written the answer. What is this? It's a case of iron overload stage. Am I right? So it's a iron overload state. Females by default, they are anemic. Pan globe, 80% of the female are anemic, especially in the reproductive age group because of monthly menses. So they are losing blood and they are usually anemic. I would use the word usually, I never say always. So by default they are losing iron in the form of menstruation. So there is no reason why they should develop iron overload state. That's why in the reproductive age group it is practically very nil. It's very nil. It's not a problem. Even the disease is there, it will not manifest because the patient is losing iron altogether. Okay. Of course, the patient is a recessive disorder. So it may manifest after 50 years of age. But it needs a long time to develop iron in the body. So even in the patient having autosomal recessive disorder in a female, they will manifest in around 70 to 80 years, not at the age of 50 years. So that's why the disease is very uncommon in females. Pathogenesis, what I told you, this unrestricted absorption of iron. This is the key word to remember. But why? Why? Remember, normally, again the basic physiology, normally only around 10% of the ingested iron is absorbed, especially in males. Normally around 20% of the ingested iron can be absorbed in a female. In severe anemia, any cause, the iron absorption may be as high as 30%, right? In severe iron deficiency anemia, the normal physiology. So let's talk about 10% of the ingested iron in males. There is a regulation, that means if the person is taking 10, normally our diet contains 10 milligram of iron per day. So normally only 1 milligram of iron is absorbed per day. This is all normal physiology. But in these cases, excess of iron, 10 milligram taken, 1 absorbed, here the iron absorbed may be 4 to 5 milligram or 6 milligram get absorbed daily. That means the amount of blood entering, amount of iron entering the body is as high as 5 to 6 times. And that's the reason why iron overload stage occurs. But why this happen? Now we talk about genetics. So in these patients, they are recessive. There is mutation in the gene, HFE gene. Okay, HFE gene, mutation occur in HFE gene, and the mutation are, this you have to remember, C282Y, H63D, C282Y, H63D. These are the mutation. Out of these also this C282 is much more important. The mutation occur in this gene. Now what happened? What happened? So this is the intestinal cell, and here this is the lumen of the intestine. Iron get absorbed, and at the border of the cell we have a transferrin, we have a transferrin receptor, we have a here we have a transferrin receptor. Transferrin receptors are there. Okay, so transferrin receptors are there in the surface of the cell of the lumen. Now normally this HFE protein, this will regulate iron absorption by a transferrin receptor. I can give you a better example. We have a big building. In the big building there is a gate. The name of the gate is transferrin receptor. Transferrin receptor. This is the name of the gate. Normally a security guard is standing here, and the name of the security guard is HFE. He is guarding the gate. Okay, so there are people who want to come in. Large number of people, they want to come in, but this security guard allows only few want to come, rest all are not allowed. Or I can say 10 people come and he allow entry to 1. 10 milligram iron taken per day, only 1 milligram is absorbed. So 10 people come and he allows only 1 people to come in. Fair enough, understood. Suppose this security guard is not there. He is on chutti, he is on off. So that means receptor is there, gate is there. Now there is no security guard. Now many more people will come in. Excess of people will come in. So excess of people, that means excess of iron will come in. But what happened to this gentleman in hemochromatosis? The gene controlling this got mutated. Mutation occurs, and that's why iron is coming in. The problem is excess of iron absorbed. I hope you understood the meaning. Okay, so this is the chromosome 6, where we have HFE gene, which normally take care of the transferrin receptor in the intestine. Mutation occur in this, that's why unregulated extra iron get absorbed. So unregulated iron comes in, and there is excess amount of copper coming in every year about 0.5 to 1 gram of iron, 1 gram iron, excess iron is accumulated in the body. Point to be noted, this excess iron start coming from childhood, but it manifests only when a sufficient amount of iron is there. That's why it also manifests in the middle age, not in the childhood. So iron is again, excess of iron in the body, it produces free radicals, and the free radicals, they lead to damage the tissues and they may cause fibrosis. So the keywords to remember in this are, but all you have to remember keyword is, the keywords are unrestricted iron absorption, mutation in the HFE gene, missense mutation are C282Y, H63D, chromosome 6. So there are 4 keywords, 1, 2, 3, 4 keywords in this particular slide. And transferrin receptor, where HFE gene comes and regulate. So only one keyword is transferrin receptor, and after that unregulated iron absorption. There is increase in the total iron content in the body 0.5 to 1 gram per day, and ultimately they produce free radical which cause damage. So there are 3 keywords in this particular slide: unregulated expression of iron uptake, about 1 gram of iron, extra iron come every year, and free radicals are produced. So point to be noted that when the extra iron is about 20 gram, minimum 20 gram we need to have the patient to have manifestation. And just in the previous slide we learned that about 0.5 to 1 gram of iron get absorbed, extra iron is coming every year, 0.5 to 1 gram. So that's why they present only at the age of around 40 years. This is the reason they do not manifest in the child, although it's a disease, a autosomal recessive disorder. Okay, so only 40-year male. Now you know the reason why I'm focusing on the point 40-year age. Okay, this is the reason for that, right? So now they will come with a sign and symptom of typical of so-called hemochromatosis will be there. So what are the signs and features that we are going to have in hemochromatosis? Right? Well, it get deposited in many organs, especially in the liver. The two things which really bother is cirrhosis of liver and carcinoma. Point to be noted, the excess of copper which is coming in the liver can lead to cirrhosis, which can again lead to carcinoma. So the three keywords are 20 gram, 40 years and two problem. Two problem, carcinoma and heart in the liver, carcinoma and cirrhosis. Two. And 20 gram, 40 years. Two problem in the liver, 20 gram, 40 years. So three keywords, 2, 20 and 40 are the three keywords in this particular slide. So now how the patient come to us? Patient may come with cirrhosis with hepatomegaly. Patient may even have liver enlarged. Normally in some cases of any cause of cirrhosis, it may shrunk also, but here it may be hepatomegaly. So you can see the normal liver size, but here the liver is enlarged. You can very well compare the two figures. You can very well compare the two figures. Hepatomegaly occurs. Point 1. Point 2, in the heart, it can lead to restrictive cardiomyopathy. Of course, in some cases, even dilated cardiomyopathy can occur. But for all practical exam point of view, restrictive cardiomyopathy is the main presentation. This is the cardiac problem. In the skin, where excess of iron, it leads to skin pigmentation, particularly in the sun exposed area. And these patients, excess of iron can go in the pancreas. In the pancreas, it can lead to diabetes. So diabetes with skin pigmentation, we use the term as bronze diabetes. So friends, the first keyword is cirrhosis of liver. Second keyword is restrictive cardiomyopathy. Third is the skin pigmentation. Fourth is the bronze diabetes, that is patient has hyperglycemia with skin pigmentation is bronze diabetes. So now you can see the skin pigmentation. You can see in these clearly you can compare. Impotency, loss of libido and testicular atrophy. Testicular atrophy is an important clinical features. And the testicular atrophy will happen, so definitely it will lead to loss of libido. And not only that, there is destruction of pituitary gland, and that also lead to hypogonadism. In these cases, ladies may develop amenorrhea. But again, point to be noted, this is not a common problem. Uncommonly amenorrhea. Amenorrhea means we are dealing in the reproductive age group, right? Reproductive age group we are dealing, but it is uncommon. In contrast to loss of libido in men, this is much more common as compared to the amenorrhea in females. Okay, so and there can be hepatoma formation. Liver cancer can occur in this patient. So by and large, in the males, it is a libido, testicular atrophy or hepatoma can develop. So lovely slide. Normal liver, cirrhosis and hepatocellular carcinoma. The cancer has occurred. Three things seen in a single slide. Arthritis, classically in the second and third metacarpophalangeal joint, second and third, and you have seen the X-ray also. classical exam question is this. Okay, arthritis. Now one more thing. Of course, this is the classical feature that we see. But additional thing which can happen in this patient is pseudo gout. Which usually tend to occur in elderly people, and the patient may have joint pains, knee joint pains. And whenever you get a question on pseudo gout, of course, hemochromatosis is a cause of pseudo gout. But one classical question which is really give a clue that you are dealing with pseudo gout is meniscal calcification. So if you take X-ray of the knee joint and if you find if you are getting meniscal calcification, so you are dealing with pseudo gout, and one of the causes of pseudo gout is hemochromatosis. Okay, lovely picture. So now lab finding. Transferrin saturation is the best initial screening test. How we really calculate transferrin saturation? Serum iron divided by total iron binding capacity. TIBC stands for total iron binding capacity. Serum iron TIBC. In fact, in these patients, serum iron level is very high and TIBC is reduced. So definitely, if is more than value 45%, this indicate we should investigate further. So the best screening test is transferrin saturation, best screening test, and how we calculate serum iron divided by TIBC. If the value is more than 45, further screening should be done. Increased serum iron, and in these cases, this increased serum iron and ferritin level are increased. Point to be noted, ferritin is not a best screening test, although ferritin level is increased, but ferritin we use for follow-up therapy. We do the therapy and later on we want to see what the outcome, then our aim that the ferritin should be in the normal range. So what I want to convey the message, initial screening is transferrin saturation, but for follow-up we use serum ferritin. Total iron binding capacity is reduced, and in fact TIBC is reduced and total iron is increased. Total iron is increased. That's why the saturation is more than 45. LH and FSH level are reduced because of damage to anterior pituitary. But very important point, gold medal, ranked number 1 question. RBC count is normal despite high serum iron. It is one condition where the RBC count is normal. This is sharp in contrast to condition like polycythemia vera. In polycythemia vera also the serum iron may be high, but here RBC count is very high. Here RBC count is normal. This is a gold medal question is this. Okay. So normal RBC count with increased serum iron, think about hemochromatosis. Write down golden line to remember. Increased serum iron with normal RBC count, you think about hemochromatosis. Simple. Okay. Finally, this was the liquor. So the keyword are this keyword. The liver biopsy is done to confirm it. And we always check for the iron content in the liver biopsy piece. If it is extra, that is the most accurate test. So you can see rusty color gross, and you can see that total in the biopsy you are getting lot of iron, and we stain by Prussian blue. For iron we use Prussian blue stain. Okay, we can do MRI of the liver also, just to add on to the investigation. And you must always screen the relative for FEE gene testing for C20 282 C282Y mutation. I told you there are two mutations, but this is much more. To all, remember, it is autosomal recessive. So all relatives should be investigated for this gene. Well, extra important point, those patients who have hemochromatosis, they are increased risk of certain siderophilic organisms. This is very important question for microbiology. There are certain bacteria which feed on iron. They need iron as their diet. These patients are more prone to these siderophilic organism. Question for microbiology, what are the organisms? One is Vibrio vulnificus. It is a single flagella organism. Vibrio vulnificus. We have other bacteria. This is Listeria monocytogenes. Point to be noted, in Vibrio there was single flagella. Here we have multiple flagella are there. Finally, we have a Yersinia enterocolitica. There is no flagella. Yersinia enterocolitica. So these three are siderophilic organisms which are usually asked in the exam. Porphyria cutanea tarda. It's a type of porphyria where skin involvement is there. It can occur. Extra H, Porphyria cutanea tarda can also occur in hepatitis C. Point to be noted. Most common cause of death in treated patient is hepatoma. But the most common cause of death in untreated patient, untreated and treated patient. Untreated is congestive heart failure. In treated is hepatoma, so-called hepatocellular carcinoma. Management, weekly venous section. What is this? We take out so-called phlebotomy. The other name of venous section is phlebotomy. You take out the patient blood every week. That means other way around. We ask the patient to donate the blood. Donate the blood. Okay. So when you have to talk to the patient, you have to say in your body excess of iron is there and we want to take out the blood. Something very funny. Normally it is for a patient. For a patient we give blood transfusion. But this one condition, we take out the blood as a treatment plan. So this is what we use as phlebotomy or so-called venous section is the other term that we use. We also use iron chelator. Desferoxamine is parenteral. It can be given IV or subcutaneous. We have oral, that is deferopon and deferoxoc. Most difficult name, but don't worry, I'll make it very simple for you. So there are three names in front of you. Each one is common with defer. This is common. Okay, so we have a defer, iPhone, iPhone. The term common iPhone. This is iPhone, quite easy to remember. Acrox, oxamine. iPhone, Acrox and oxamine. Very simple. Okay, so 3 iron chelators. Right? Well, then, so this is how we are going to manage. A quick recap of LMRP. Iron is increased and that lead to damage to several organs. It is autosomal recessive. Chromosome 6 is involved, mutation in C282Y or H63D. The clinical features are cirrhosis, diabetes mellitus, so-called bronze diabetes, gray pigmentation of skin, restrictive cardiomyopathy, arthritis, especially pseudogout or second and third metacarpophalangeal joint, porphyria cutanea and hepatoma can occur. Increase serum ferritin, increase serum iron and increase transferrin saturation. But TIBC, total iron binding capacity, is decreased. Liver biopsy, the most accurate test, and you stain by Prussian blue. Weekly venous section, an iron chelator, defer iPone, Acrox or oxamine. These are the iron chelators. Golden line to remember: cirrhosis, diabetes, skin pigmentation, restrictive cardiomyopathy in a young middle-aged men. You think about hemochromatosis. Okay, so thank you very much and God bless all of you.